Welcome back to the deep dive. Really glad you could join us. If you're an orthopedic resident, maybe prepping for the FRCS or similar fellowship exams, or you just want to get a really solid handle on a super critical trauma topic, well, you're definitely in the right place. Today, we're jumping headfirst into pelvic fractures. It's complex, no doubt, but absolutely essential. This whole deep dive, it's built for you. We're aiming to boil down the really crucial stuff, the actionable insights. It's all based on the excellent Ortho Made Simple notes you can find over on mokyingren.sg. They were put together by Dr. Mok Ying Ren. He's a sports surgeon at National University Hospital in Singapore, finished his FRCS back in 2022.
That's right. And pelvic fractures, they're not just, another fracture pattern. They can be some of the most challenging, most life-threatening injuries you'll encounter in the trauma bay. So our goal today is really to cut through all the detail, give you that high-yield, quick, but still thorough understanding, get you those key takeaways that stick, for the ward, for the OR, and definitely for those exams.
Exactly. So picture this. High-energy trauma rolls in. You suspect a pelvic fracture. Your brain needs to immediately go, okay, how bad is this? And critically, what else is going on? Is this patient bleeding out somewhere I can't immediately see? Which brings us right to the fundamentals: classification and stability. Let's start with Young and Burgess. It's often the first one we learn, right? Why is it so significant? How do you break it down quickly?
Yeah, Young and Burgess is fundamental because it's all about the mechanism. How did this happen? That tells you a lot about the likely severity and, crucially, the associated injuries.
Yeah.
It groups fractures based on the direction of the force. So first up, you've got posterior compression, APC. APC1, that's your sort of lowest grade. The symphysis might widen a bit, but usually under 2.5 centimeters. It's generally considered stable.
Okay, relatively stable.
Then APC2. Here, the anterior sacroiliac joint, the SIJ, is disrupted. You see more symphysis widening, over 2.5 centimeters. So the front is definitely opening up.
Right.
And APC3. Well, that's the big one in this group. Both the anterior and the posterior SI ligaments are gone. Complete disruption, front and back. Often catastrophic rotational instability.
Okay, so APC is force from front to back or vice versa. What about side impacts? Lateral compression or LC? How do those look?
LC injuries are different. Often more subtle initially, maybe. LC1 typically involves pubic rami fractures on one side, plus sacral buccal fractures on the same side. Think of the pelvis kind of crumpling inward.
That buckle, right. Not a complete break necessarily.
Exactly. Then LC2, the energy's higher. Now you get an actual fracture of the iliac wing on the same side, sometimes called a crescent fracture. That tells you the force was pretty significant, and you start worrying more about posterior stability.
Makes sense.
And LC3 is where it gets really unstable. The force has basically gone right across the pelvis, and now you have involvement of the contralateral SI joint. So an injury on the opposite side from the main impact. Highly unstable pattern. And then quickly there's vertical shear, VS, almost always super high energy, like a fall from height. One whole side of the pelvis is shifted upwards relative to the other. Very unstable.
So we have these patterns based on FORT, APC, LCVS.
Yeah.
But the real clinical question is stability, isn't it? How do we connect Young and Burgess to stable versus unstable? Because that's what drives the immediate management.
Absolutely. Stability is everything. That's the immediate translation you need to make. So generally, your stable ones are APC1, LC1, and usually LC2 because the posterior ligaments are often intact, or at least partially. But APC2, APC3, LC3, and vertical shear, those are all considered unstable. And what's interesting here, this naturally leads us to the tile classification. Young and Burgess tells you how it broke. Tile tells you how unstable it is mechanically.
Ah, right. Tile. How does that complement Young and Burgess? Does it simplify things for deciding on treatment?
It does. It really focuses purely on mechanical stability.
Wow.
Think of it like this. Tile type A, stable. These are fractures that don't disrupt the pelvic ring integrity. Maybe an avulsion or an isolated pubic ramus fracture or iliac wing fracture without posterior involvement, often non-op.
Okay.
Tile type B, rotationally unstable, but vertically stable. This is where many of those Young and Burgess types fit in: APC 1, 2, 3, LC1, LC2. The pelvis can sort of spring open or closed, but it shouldn't shift upwards significantly. The posterior tension band is compromised, though.
Got it. Rotationally unstable.
And tile type C, the worst category. Rotationally and vertically unstable. This is your LC3, your vertical shear, or maybe any pelvic fracture combined with an acetabular fracture that disrupts the ring. Highest energy, requires fixation.
And just practically speaking, in a busy trauma center, what's the most frequent pattern you actually encounter? Is there one type that dominates?
Well, in severe high-energy trauma, you often see mixed patterns. It's not always purely one type. Maybe a combination of lateral compression and some vertical shear component is actually quite common. These are complex, definitely needing surgery.
Okay, classification and stability check. Foundational stuff. But, as we said, the bone is only part of the story. Now, this is where it gets, well, really critical for the patient's survival, the associated injuries. Pelvic fractures bleed, and they damage other things. Let's talk urethral injuries. Is there a specific fracture finding that should make you immediately think, uh-oh, check the urethra?
Yes, definitely. Especially in males. If you see an inwardly displaced parasymphyseal fracture, so a fracture near the pubic symphysis pushed inwards by more than a centimeter, your suspicion for urethral injury needs to be sky high. That fragment can directly injure or shear the urethra.
Right, 1 centimeter inward displacement near the symphysis.
Yeah.
Got it. And the big one, hemorrhage. Where does most of that life-threatening bleeding actually come from? And which fracture type carries the worst prognosis for bleeding and mortality? It's often misunderstood, isn't it?
It is often misunderstood. Everyone immediately thinks artery, but the vast majority of pelvic fracture hemorrhage, probably 80–90%, is actually from the extensive venous plexus surrounding the pelvic bones and organs, and also from the fractured cancellous bone surfaces themselves. Arterial injury only happens in maybe 10–15% of cases. When it is arterial, though, it's serious. You worry about the superior gluteal artery, especially with posterior ring injuries or APC types, and the internal pudendal and obturator arteries are more at risk with LC types.
Okay, mostly venous plexus and bone, so which pattern bleeds the most?
Hands down, APC3. That complete disruption opening the pelvis like a book just tears everything. Highest blood loss, highest mortality. In general, you can think of the bleeding risk like this. APC patterns tend to bleed more than vertical shear, and vertical shear tends to bleed more than lateral compression.
Okay, APC3, highest bleeding risk. What about other injuries? Head injuries, for example. Is there a link between a specific pelvic fracture type and associated head trauma?
Yes, there is. LC3 fractures actually have the highest reported association with concomitant head injuries. And just generally, lateral compression injuries overall seem to correlate more frequently with associated chest and brain trauma compared to APC types, maybe related to the site impact mechanism often involved.
Interesting. So as a resident assessing these, maybe the initial x-rays look not completely disrupted. Is there any subtle sign, maybe a small fracture elsewhere, that should scream, warning, this might be way more unstable than it looks?
Absolutely. A crucial one to look for is an L5 transverse process fracture, or sometimes you might see an avulsion of the iliolumbar ligament's attachment point. Seeing that L5 transverse process snapped off should immediately raise your suspicion for a significant, unstable posterior pelvic ring injury. Even if the SI joint itself looks relatively okay on the AP view, it implies a massive force went through there.
That's a key pearl. L5 TP fracture equals high suspicion for instability. And while we're near the spine, what about nerve injuries? Which nerve root is most commonly affected in pelvic fractures?
The L5 nerve root is the most commonly injured. It's vulnerable as it courses across the sacral ala near the SI joint. These injuries are particularly associated with sacral fractures, especially Denison 1 fractures, the ones involving the ala, seen in maybe 5% or so of those fractures.
Right, it really drives home that this is a central complex injury, not just peripheral bones. Okay, so let's pivot to management. The unstable patient arrives. Hemodynamically unstable, known pelvic fracture. What's the game plan? It's high pressure, life or death. What's the immediate sequence?
It's ATLS on steroids, basically. First, ATLS principles always apply airway, breathing, circulation. But specifically for the pelvis, get a pelvic binder on immediately, and crucially, center it over the greater trochanters, not the iliac crests. The goal is to close down the pelvic volume, compress those fracture surfaces, and hopefully tamponade that venous bleeding we talked about.
Binder on the GTs, check.
Then, massive transfusion protocol. Get it started early. Think 1.1.1 ratio packed cells, platelets, FFP. Resuscitate aggressively but smartly. 5E tranexamic acid, TXA. Based on the CRSH2 trial, give it if it's within 3 hours of injury. It helps stabilize clots.
Okay, MTP, TXA.
Actively look for those associated injuries, urological, GGI. Check for blood at the meatus. Do a rectal exam looking for blood or a high-writing prostate, which suggests urethral injury. An open fracture into the rectum is a surgical emergency. And then there's permissive hypotension. This feels counterintuitive, right? But you might aim for a slightly lower systolic pressure, maybe 80–90 millimillar Hg initially. The idea is to avoid blasting off the early fragile clots with overly aggressive fluid resuscitation before you achieve definitive hemorrhage control. It's a balancing act.
Right, don't pop the clot. How do you gauge if these initial steps are working?
You're constantly reassessing their response. Are they a non-responder? Do they respond briefly, then drop their pressure again, a transient responder? Or do they stabilize a permanent responder? If they're a non-responder or transiently responding despite binder and initial resuscitation, they need urgent intervention. That might mean going straight to angiography for embolization or maybe to the OR for external fixation and pelvic packing. If they stabilize, you still need to investigate. A CT angiogram is usually the next step to look for arterial bleeding that might need embolization later. Understanding their response guides that urgency.
You mentioned the binder needing to go on the GTs. How many people does that practically take? And you mentioned centering it. Any reason you wouldn't put one on?
Yeah, it's not a one-person job, especially if the patient needs logging rolling for other assessments. You probably need 4 people for the roll and 1 dedicated to sliding the binder underneath correctly. Positioning at the GT level is key for effective compression. The main theoretical concern for not using one is with some LC fractures. There's a hypothetical risk that closing the pelvis could worsen an internal rotation deformity or potentially injure viscera trapped in the fracture. But honestly, in a crashing patient, the benefit of hemorrhage control almost always outweighs that theoretical risk. Binder first, ask questions later in most unstable cases.
Okay, makes sense. And once it's on, is there a time limit? Can you leave it on indefinitely?
No, definitely not. You need to loosen it or ideally replace it with external fixation or definitive fixation, usually within 24 hours. Prolonged pressure can cause significant skin necrosis, especially over the trochanters and sacrum. It's a temporary measure.
Good point.
Yeah.
And the CT angiogram for responders, any specific protocol for that?
Yes, ideally you want a triple phase CT angio. That includes an arterial phase, a portal venous phase, and a delayed phase. This helps catch bleeding from different sources, fast arterial bleeds, slower venous oozing, or contained hematomas that might extravasate later. It gives the most comprehensive picture. And if angiography isn't readily available or perhaps fails, pelvic packing is another option, often combined with external fixation. This is done extraperitoneally, meaning outside the abdominal cavity. You make a vertical incision above the pubic symphysis, retract the bladder, and pack large laparotomy pads into the retroperitoneal space on each side, aiming towards the iliac vessels. It creates a tamponade effect. An important point, if the patient also needs a laparotomy for abdominal injuries, you should try to keep the packing incision separate from the laparotomy incision to maintain that tamponade effect in the retroperitoneum. And those packs, like the binder, are temporary. They need to come out, usually within 48 hours, to prevent infection.
Okay, that covers the acute damage control phase. Now, shifting gears to definitive management, putting the pieces back together for the long haul, external fixation is often used. We hear about low route versus high route pins. Can you break down the low route first? What are its pros and cons?
Sure. The low route, or supraacetabular X-fix, involves placing pins just above the acetabulum into the iliac body. Its main advantage is biomechanical stability. It provides stronger fixation compared to the high route. It also leaves the iliac crest free, which can be helpful for later access or if a laparotomy is needed. The disadvantages, it's technically trickier. There's a significant risk to the lateral femoral cutaneous nerve, LFCN, if you're not careful with your starting point and trajectory. You also risk perforating into the hip joint, the sciatic notch posteriorly, or the inner table medially. Precise insertion using image intensification is absolutely critical. You need those specific views, obturator oblique, to see the teardrop and ensure you're above the joint, and iliac oblique to stay clear of the greater sciatic notch.
Right, and the high route, where do those pins go? The high route pins go into the iliac crest itself. The incision is usually made about 2 centimeters posterior to the ACIS, aiming for the thickest part of the crest. You still need to be careful, stay about 1.5 centimeters away from the ACIS to minimize risk to the LFCN. You basically place pins between the inner and outer tables of the ilium.
It's generally considered less biomechanically robust than the low route, but perhaps technically a bit simpler and safer in some hands. Avoiding perforation is still key.
Got it. And then there's the pelvic C-clamp. When does that come into play?
The C-clamp is a more specialized device, primarily for temporary posterior stabilization in really unstable type C injuries, particularly those APC3 or vertical shear patterns with complete posterior dissociation. It provides powerful compression across the SI joints. Pin placement is very specific, typically at the intersection of the femoral shaft axis and a perpendicular line from the ACIS. You insert the pins, usually 1 centimeter diameter, directly into the ilium on both sides and then compress. But this brings up a really important question. When should you avoid these devices?
Yeah, good question. Are there contraindications? When would you not use an X-fix, or specifically a C-clamp?
For external fixators in general, they become less effective, a relative contraindication perhaps if you have significant iliac wing fractures like LC2 or 3. The pins need solid bone to purchase in. Also, if the posterior SI ligaments are completely gone, like APC3-VS, the X-fix loses its ability to act as a tension band to compress the posterior injury effectively. It might still help control rotation anteriorly, though. The C-clamp, however, has more absolute contraindications. You absolutely do not use a C-clamp if there are fractures through the ilium where the pins need to go, again, like in LC2 or LC3 patterns. The risk of the pins displacing through the fracture line, causing more damage or losing fixation, is just too high. You also wouldn't use it if there's significant comminution around the SI joint.
Okay, so after temporary measures like binders, X-fixes, or C-clamps, what's the gold standard definitive plan for unstable pelvic fractures? What are you aiming for surgically?
The absolute cornerstone of definitive management is this. You must address both the posterior ring and the anterior ring. Stability requires fixing both. And the sequence matters. You almost always fix the posterior ring first. This is the foundation. Usually this means placing sacroiliac SI screws, often percutaneously with the patient supine. Once the posterior ring is stable, you address the anterior ring. This typically involves either plating the pubic symphysis, often through a Fannin-style incision, or sometimes using an anterior subcutaneous internal fixator, or infix. If there are separate iliac wing fractures, those might need screw fixation too, sometimes using a similar trajectory as the low-route X-fix pins.
You mentioned symphyseal plating versus an infix for the anterior ring. Why choose one over the other? Are there patient factors?
Yeah, there are considerations. The infix can be appealing for, say, very obese patients where a Fannin-style approach might be difficult, or perhaps in women of childbearing age because it's designed to be removed later, avoiding potential issues with childbirth. But the infix has a significant downside, a reported risk of injuring the LFCN as high as 25%, and it mandates a second surgery for removal, usually around 3 to 6 months later. Symphyseal plating is more traditional, potentially avoids the specific LFCN risk of the infix if done carefully, and doesn't require removal. So it's a trade-off. And those SI screws for the posterior ring, getting them in the right place is critical. Talk about the safe zones. How do you avoid disaster back there? Oh, absolutely critical. The safe zone for an S1 SI screw is quite narrow and defined by multiple views. On the lateral view, you need to stay posterior to the iliac cortical densities. Going anterior risks the L5 nerve root. On the inlet view, the screw must be entirely within the bone of the S1 vertebral body, not straying anteriorly into the canal or posteriorly. And on the outlet view, you need to be cranial, or above, the S1 neural foramen to avoid injuring the exiting S1 nerve root. Straying outside the zone in any plane puts the L5 or S1 roots at significant risk. It requires meticulous fluoroscopic guidance.
And what if the patient's anatomy isn't normal? What about sacral dysmorphism? How does that change things?
That's a huge point, and something you have to assess on the pre-op imaging, usually the CT scan. Sacral dysmorphism means the upper sacrum isn't as wide, or maybe the S1 body isn't nicely recessed between the iliac wings, and often there's a sharper angle. This makes that safe corridor for an S1 screw much narrower or even non-existent in the standard trajectory. You might have to angle the screw more obliquely, maybe more superiorly and anteriorly. In some severe cases, you might not be able to safely get a screw into S1 at all, and you might have to consider placing transsacral screws or SI screws into S2 instead. It definitely complicates things.
Wow, yeah, critical detail, especially for exams. Okay, one last area to touch on briefly. Fragility pelvic fractures. These are becoming more common, right? How are they different?
They are definitely increasing as the population ages. Fragility fractures are different because they happen with low energy, like a simple fall from standing, in patients with osteoporosis. The bone quality is the main issue. We use a different classification for these, the Raman's classification. Type 1 is just an anterior ring fracture. Type 2 is a non-displaced posterior ring fracture, usually involving the sacrum unilaterally. Type 3 is a displaced unilateral posterior ring fracture. And type 4 involves displaced bilateral posterior ring fractures.
And does the management differ significantly based on that Raman's type? It sounds like maybe not all of them need surgery.
Exactly. Management is often guided by pain and mobility, especially for the lower types. Raman's types 1 and 2 can often often be managed non-operatively with pain control, maybe protected weight bearing, and mobilization is tolerated. But type 3, the displaced unilateral ones, they often don't heal well without surgery and cause persistent pain and immobility, so surgery is frequently recommended. And type 4, with bilateral posterior instability, those almost always require surgical fixation to restore stability, manage pain, and allow the patient to mobilize. So the approach is definitely tailored. It underscores that principle. Knowledge is most valuable when you understand it well enough to apply it correctly to the specific patient situation.
That's a fantastic summary. We've really covered the spectrum, haven't we? From the core classifications like Young and Burgess and Tile, understanding why they matter for stability and associated injuries. We hit those crucial risks, the venous bleeding, the L5 transverse process warning sign, then the whole acute management pathway for unstable patients, binders, MTP, TXA, packing, permissive hypotension, and finally, the definitive fixation strategies, addressing both rings, the nuances of SI screws, and even those special considerations for fragility fractures. It really feels like having this organized framework, drawing heavily on those ortho-made simple notes from mokyingren.sg, gives you a powerful way to approach these complex injuries, both for exams and, more importantly, for patient care.
Absolutely. And seeing how it all connects: classification, predicting risk, risk driving acute care stabilizing for definitive fixation, that's where deep understanding comes from. It moves you beyond just knowing facts to actually thinking like an experienced surgeon. Hopefully this gives you a solid platform for that.
Couldn't agree more. It's about connecting those dots for the aha moments. A massive thank you again to Dr. Mok Ying Ren for the ortho-made simple notes on mokyingren.sg that formed the backbone of this discussion. We really hope this deep dive has armed you with some valuable tools and insights. Thanks for joining us, and until next time, keep digging deeper.